All right. We're talking about urinary system disorders, chapter 18. We're moving on through unit 2. We're now in the third chapter. So, a urinary system, what's the goal of the whole thing here? Well, remove any metabolic waste, remove drugs, other foreign material. Big part of regulating our water, electrolyte, and acid base balance. So, I mentioned before, if you want to think about the one organ system that's super important for chapter 2 stuff, regulating water, electrolytes, and acid balance, it's going to be our kidneys and the urinary system. And also helping to regulate blood pressure through the RAA system, renin, angiotensin, aldosterone system. So, kind of the flow of everything is the kidneys do the big legwork with their nephrons. They take blood flow, filter it, turn it into filtrate, and eventually make it into urine that flows to the ureters, gets held by the urinary bladder, and then out the urethra toilet. That's kind of the flow of everything. The nephrons are what you would call kind of the functional, or I like to say the functional filtration units of the kidneys. Each kidney has around 1,000,000 nephrons. The components of the nephron is basically twofold. There's a renal corpuscle and renal tubules. The renal corpuscle is the glomeralis surrounded by the Bowman's capsule. The renal tubules consist of tubes, basically. There's a proximal, and if you kind of remember the A&P, proximal, distal. Proximal means closest to the point of origin. Distal means furthest away from the point of origin. So the origin of these tubes is right after the renal corpuscle. So you got proximal, big loop that loops down through the nephrons down into the lower portion of the adrenal medulla, back up into the cortex for the distal convoluted tubule, and then multiple nephrons will meet together at a collecting duct. So if you want kind of an image of that here, here's your image. So again, it's looking at that the renal corpuscle is just this section here. Right here, basically. And then you're going to have things like the renal tubules that extend here, basically. So you'll have your proximal convoluted tubule, loop of Henle, distal convoluted tubule, and then multiple or one collecting duct collecting multiple nephrons, basically. And the whole process is about pushing blood through here, what's called a glomeralis, pushing out fluid and minerals into the Bowman's capsule, and that makes it filtrate. And then the rest of the tubule's job is all about reabsorption, either letting go of things and letting them stay in the tubules as they go, or reabsorbing them back into blood flow, depending on what kind of the concentration is, depending on principles like osmosis, those kind of things. So filtration, when we push that blood, gets the things from the glomeralis, pushes high pressure, it pushes stuff out in the glomeralis, pushes it into the Bowman's capsule. It's now known as filtrate. And so filtrate is this large volume of push of fluid, right, out of the glomerular capillaries. And this could be definitely a lot of waste, but it can also be components we do want to keep, nutrients, electrolytes. The reabsorption process happens through the tubules. Slowly, the tubules will reabsorb the nutrients, water, and other electrolytes. And kind of what's left, hopefully, will be electrolytes or other things we don't need, including like uric acid, urea, nitrogenous waste components, acids, those kind of things. And this is how we control acid-base balance and electrolytes. So some hormones that play a huge role in this that you always have to know. There's ADH, antidiuretic hormone. This is made by the hypothalamus and secreted by the posterior pituitary. Its goal is to get water reabsorbed in the distal convoluted tubule. So distal convoluted tubule, it's where ADH is acting, and it's trying to get water reabsorption. And that will increase blood volume and increase blood pressure because of that. Aldosterone wants the same thing. This is a hormone secreted by the adrenal glands, specifically the adrenal cortex. And this basically says, let's reabsorb more sodium in exchange for potassium. And this will raise sodium. What does salt do? Salt sucks. So this raises water level too. And then we'll accomplish the same goal as ADH. The increased blood volume, increased blood pressure. So aldosterone and ADH work together. They worked in tandem. They just to increase blood volume and fluid status and that sort of stuff, but they just do it in a different mechanism. Aldosterone's more about the tubules themselves targeting sodium, whereas ADH is more about specifically allowing the collecting duct areas to reabsorb more water back into the vascular. Sure. So which hormone increases water reabsorption in the distal convoluted tubule and collecting ducts? The key to that is water reabsorption. The latter is about sodium reabsorption, which then water follows. So in that case, correct answer is number 4, ADH. So glomerular filtration rate. Glomerular filtration rate, known as GFR, is really the kind of gold standard for kidney function and the effectiveness of the kidneys themselves and the nephrons of doing their job. So control of GFR is based on 3 factors. We have our own mechanisms that'll help auto-regulate. So locally, we're going to change the diameter of the glomeralis and the local arteries, and this is going to change the response in blood flow. The nervous system can cause vasoconstriction, and then we have a component that's local to some cells called juxtaglomerular cells that sit in this artery coming into and out of the nephrons to regulate blood flow and to regulate blood pressure. And basically what happens, the RAA system, if you kind of talked about this before, but this is the renin, angiotensin, aldosterone system, generates renin in response to drops in blood pressure. So basically the juxtaglomerular cells read drops in blood pressure and they go, okay, renin does its system of being converted to a couple different enzymes to eventually make aldosterone be released. What does aldosterone do? Again, reabsorb sodium, therefore increasing blood volume and increasing blood pressure. And so that's the regulation part of that. So some other urinary things to talk about, moving away from just the kidneys and how they function. That was more that was an A&P discussion about the kidneys. So we're moving from that to talk about urinary system as a whole. One big thing that we deal with in nursing a lot is incontinence or urinary retention. So incontinence, definition wise, is just loss of voluntary control of the bladder. And there could be a number of reasons why someone has incontinence. For example, diabetes can actually cause this. Pregnancy, childbirth, those that have given birth or have children and been pregnant know that stress incontinence, like from sneezing or whatever, is common. Overactive bladder, and a large prostate in males, just a general weak sphincter muscle, urinary tract infections can cause this. Other diseases, spinal cord injuries, specifically, that would be like a neurogenic bladder is what that's usually referred to. Urenesis or neuresis. Urenesis is involuntary control for a child 4 to 5 years old, when you would expect bladder control to be, or you would expect a 4 to 5-year-old to have bladder control. Most children are going to suffer from not what's called nocturnal urenesis. You got nocturnal urenesis as bedwetting. And again, incontinence has different types, like stress incontinence is the one of the more common in women because of the childbirth and the weakening of that muscular sphincter around that area, that sort of thing. Overflow incontinence is another common one. This is basically incompetent bladder sphincter. This is more common in older adults where the bladder fills up enough that the muscle is just not weak enough to kind of maintain and hold urine flow, hold urine back, and therefore it leaks out of the urethra. So weakened muscle, this can lead to them needing to go frequently and having incontinent episodes around that. Retention just means inability to empty the bladder effectively. Generally, you're going to see this. You can see this with older adults. You'll definitely see this with males suffering from um, prostate, enlarged prostate. Most common that we see in healthcare is going to be following just any anesthesia, general. So, like fully putting under or spinal local anesthesia can cause a delay of the nervous system response to the bladder. And it tends to be one of the things that's very common from that. So testing, we can always do the basic test as a UA, urinalysis. And this is looking for like the appearance, really. Is there an odor? What color is the urine? Is there an odor involved? That sort of thing. And then it looks at some other factors too. A UA can tell us a lot about somebody. So we're thinking about UAs and urinary infection. Like, what are we looking at? Typically, there's going to be probably some purulent drainage in that UA, so it's going to be very cloudy. Might have a frank smell, and there's going to be usually positive bacterial organisms. Some of the most common is gram-negative, gram-positive organisms. Those are just different forms of bacteria that are more common. So again, in urinalysis, this is a good summary of kind of the things you don't want to see in a UA. And the things you don't want to see in a UA is obviously like blood, protein, bacteria, urinary cast, elevated specific gravity. You don't want to see glucose or ketones. So blood shouldn't be there. Protein really shouldn't be there at all. Shouldn't see bacteria for obvious reasons. Urinary cast usually indicates injury to the nephrons because those are like tubule cells that fall into urine. They shouldn't be there. So usually like inflammation or acute injury to the nephrons. Specific gravity being up. So urine specific gravity is a measurement of dehydration we talked about before, but typically again, urinary specific gravity measures like concentration of sodium compared to fluid status of urine. And so it should be lower. The higher the urine specific gravity, the more indicative of dehydration or other issues it could be. Ketones is uncontrolled, usually like diabetes. Glucose, we usually utilize glucose pretty well in our body. And so the only reason I should find glucose in someone's urine is it's an excess and the body's trying to get rid of it, which would indicate diabetes problems. Blood tests go to that BUN, blood urea nitrogen or nitrogen, creatinine blood levels. Those BUN and creatinine would be elevated in kidney function being not as optimal. Acidosis, we're going to see pH, anemia, electrolyte imbalances, elevated renin levels could indicate other kidney conditions. Culture and sensitivity, these are going to be, again, studies that are more looking for urinary tract infections. So if we're trying to do it, we're concerned about a UTI for somebody, we do an UA to kind of look for certain things, but also we're going to go and take that urine and put it on a swatch and let it see if it grows anything. If it grows bacteria, then that's bad. Sidebar for patients that have kidney failure, like the chronic kidney failure, there's kind of two forms of dialysis. Dialysis is basically a word that is talking about a mechanical methodology for replacing the kidneys, basically. So what dialysis does is it provides filtration and reabsorption when a person's kidneys can no longer do that effectively. So there's two forms that we know of really that we use. There's hemodialysis, which is basically taking the blood out of someone's body in a certain time period, putting it through a dialysate machine that does the work of the kidneys when they can't be done, and then putting that blood back into someone's body. Peritoneal dialysis does it slightly different. Peritoneal dialysis basically allows the membrane that the peritoneum has and the vasculature of the peritoneum to do the dialysis for us. And this comes with some other inherent risk, and only certain patients can fit the category for peritoneal dialysis. This is the goal of dialysis, to sustain life during kidney failure, whether that's acute kidney failure, we can do dialysis to kind of, keep someone alive and keep the filtering and reabsorption process going until we can restore some kidney function. And people that have chronic kidney disease or at the end stage of their kidney failure and are waiting for transplant or just trying to keep quality of life, we can use dialysis in that scenario. So other disorders of the urinary system, we kind of backtrack. So big ones, urinary tract infections. Those have two subcategories called cystitis, or you can call it urethritis, but usually it's cystitis or pyelonephritis. Cystitis basically just means an infection, small time of the bladder, basically. So cystitis is a bladder infection. Pyelonephritis is an actual kidney infection, and we'll talk a little bit more about these, but you can guess which one's probably more concerning. Yeah, it's to be the pyelonephritis. Pyelonephritis would be more concerning because we actually have an infection at the kidney level and we're closer to blood flow, and that can mean risk of infection moving into the bloodstream, causing more systemic symptoms than just the bladder infection. Inflammatory disorders, glomerulonephritis, sometimes referred to as nephritic with an I syndrome. I'm capitalizing that because the other end of the spectrum is nephrotic syndrome, and we'll talk a little bit about the differences between these two. These are kind of your common kidney or urinary tract disorders. So UTI is one of the most common things. Most common infection probably you're going to see urine, because of it's pretty acidic and it has a lot of waste products that bacteria like to use as their food and their energy resources. So very common that urine is a great home for growing bacteria. Lower respiratory tract lower urinary tract infections is cystitis. Upper would be a kidney infection, pyelonephritis. The most causative organism, so the most common organism that's going to be causing UTIs is E. coli. And that's because that's the most common normal flora we have in stool. So typically urinary tract infections are going to come for a number of reasons, but typically the bacteria that's involved is going to be E. coli, most typically. So they're more common in women and older men. Why are they more common in women? Well, think about anatomy for a second. Women have a physically shorter urethra, and women also have a urethra that has closer proximity to basically infectious agents. So think stool from anus, rectum, close proximity, and vagina actually has its own normal flora. So the vagina as well has its own normal bacteria. So for women, it's more common for poor hygiene, but just it's more common in general just because the risk is higher. It's much easier for bacteria to travel from somewhere like vagina or be, contaminated from stool and make its way up a shorter urethra that's only a few inches, 2 or 3 inches, to male urethra that runs the length of the penis, and that could be 6, 7, 8 inches to get to the bladder. So much longer for distance to travel for bacteria to get to men's bladder to cause cystitis versus women. That's one of the main reasons more common in women. Any abnormalities in the urethra and anatomy for children will be more common to cause it. And then other predisposing factors more prone to infection. Pyelonephritis is one or both kidneys are involved, and this means the infection has moved from cystitis up the ureter. So this would usually happen if someone had a UTI, they kind of ignored the symptoms, they didn't have any treatment, or UTI and the treatment didn't work and the infection made its way up to the kidneys. They're going to create some purulent exudates in the calyxes and the renal pelvis of the kidneys. And it's going to could cause obstruction, mess with just general nephron tubal function. Could cause something like buildup of filtrate. This condition is called hydronephrosis, like hydro, like fire hydrant in water. Hydronephrosis is fluid buildup on the kidneys, and this is this can happen if there's an obstruction, or in this case, pyelonephritis causing this buildup or drainage from the bacterial infection. and it could lead to kidney failure and have a lot of other signs and symptoms that are more systemic than a local cystitis. So elevated white blood count, fever, um, those kind of more systemic side effects and things and signs and symptoms you would see, not side effects necessarily. Signs and symptoms you would see is more systemic for pyelonephritis, flank pain, fever, elevated white blood count. You might see some of that with cystitis, but less common. So on the inflammatory disorders, you have glomerulonephritis, which again falls under the family of nephritic syndrome with an I, nephritic. Typically, the traces of glomerulonephritis can be multifactorial, but a lot of times they trace it to this anti-streptococcal antibody. So after someone has had a strep infection, like strep throat or any other streptococcal infection, they form antibodies against the streptococcus bacteria. But for some reason, that typically this antibody can mess with and clog up the glomeruli of our nephrons. And if they indicate basically this complex is just going to cause inflammation. So if you hear glomerulonephritis, it ends in itis, and we know itis means inflammation. So think of inflammation of the glomeruli. And this means that if they're inflamed, it's going to increase capillary permeability. So the glomeruli are going to, the permeability, they're going to allow more things through, which means leakage of our plasma proteins and leakage of blood cells. So typically, symptom or signs and symptoms wise, someone with glomerulonephritis, you're going to see urine dark and cloudy because urine is going to be much more full of frank hematuria. So marked frank hematuria. This patient's going to have hypertension. They're going to might have some edema, and they're going to have decreased urine output, which would be oliguria. So they're going to have inflammation of the glomeruli. So that's going to cause protein leakage. So they're going to have proteinuria, but they're going to have marked hematuria. Think of glomerulonephritis as like actual damage or inflammation to the glomeruli, causing erythrocytes, causing blood to leak out. They're going to have some edema, flank and back pain because of the inflammation, and elevated blood pressure. That's going to be glomerulonephritis. So they're going to have elevated BUN, creatinine. They're going to have definitely proteinuria and hematuria, but think more hematuria and the erythrocyte casts. That's like your immature erythrocytes, typically not evidence of infection. And this is kind of showing you the streptococcal infection leading to glomerulonephritis, how that kind of works. Don't have to know. This isn't necessarily a need to know. This just talks about that this antibody tends to deposit in the glomeruli. So if I said there's a condition characterized by presence of anti-streptococcal antibodies and results in inflammation of the glomeruli, that is, yeah, pretty obvious. That is glomerulonephritis, also known as nephritic syndrome. So nephrotic, with an O, nephrotic syndrome is glomerular capillaries increase permeability, and so they lose large amounts of plasma proteins, infiltrate large amounts of proteinuria. So the difference here is if you look at glomerulonephritis and nephritic syndrome, it's much more inflammation around the glomeruli. So blood cells get through. So marked hematuria, erythrocyte casts, so dark urine, high blood pressure. Nephrotic syndrome is lots of marketed proteinuria, going to have low protein, low albumin in their large amount of low albumin in their blood, which that's hypoalbuminemia. It's a tough one to say, isn't it? And they're going to have generalized edema from this. So there may be some edema with nephritic or glomerulonephritis, but nephrotic is going to think of it, the difference being large amounts of edema, large amounts of proteinuria. Blood pressure might be up, might be normal. Okay. But It's going to be a really like milky, fat, and lipid appearing urine, that sort of thing. So that would be the difference, kind of, if you're trying to think again. Marked proteinuria, lipiduria, massive edema, going to have generalized growth across the field. So what do patients with nephrotic syndrome develop edema? Why do patients? Give you a second to answer that one. Yeah, if you answer loss of albumin reduces plasma onconic pressure. So basically, the plasma loses that osmotic pressure balance and fluid shifts. So moving forward, urinary tract obstructions. Urolithiasis is kind of where we're hitting on this. Urolithiasis is renal calculi, renal stones, kidney stones. So urolithiasis is the fancy name for kidney stones, basically. The other fancy name for them is renal calculi, to talk about stones. So they develop anywhere in the urinary tract. They could be large or small. They tend to form with large amounts of insoluble salts that the filtrate, or it could be that there's too much in the filtrate, or there's not enough fluid intake overall systemically, and that causes buildup in the filtrate. That would be things like decreased fluid intake, immobility, urine stasis, maybe from urinary retention. But most commonly, it's going to be calcium salts and a mixture of calcium salts and uric acid. So the chemicals that form urolithiasis, kidney stones, is going to be calcium salts and uric acid. And the manifestations, what's going to be the signs and symptoms related to usually obstruction of flow and pain. So there may be stones in the kidney or bladder. They could be asymptomatic and relate to frequency of infections, can go hand in hand with this. But most of the time for kidney stones, it's going to be flank pain, kind of that lateral lower abdominal back to stomach flank pain. As the distension of the renal capsule happens, if there's fluid buildup in there, it's going to cause spasms in the ureter, potentially, and inflammation in the ureter. Also, the same thing in the bladder itself. And again, they could have nausea and vomiting, but typically it's going to show stones. Pretty much the key to stones is going to be pain. And then for us, it's straining their urine and checking the patient. And a lot of times for stones, there are procedures to go and actually physically remove the stone. It's called a lithotripsy. If that's not an option, sometimes there's mostly treating pain and making sure that there's no physical obstruction that happens. So finishing off renal failure, we talked about dialysis. Renal failure in general has acute or chronic. Again, acute means like sudden onset, very kind of high level symptoms that can be resolved. So what's causing it? Any kidney disease can cause this, really. Your glomerulonephritis, nephrotic syndrome, prolonged circulatory shock, or someone that has heart failure. Heart failure means they have limited and not as much functional pumping. Circulatory shock would mean there's just hypovolemia, not enough blood flow. That could lead to renal failure acutely. Nephrotoxins would be any medication or any chemical that would cause toxic effects to the nephrons. There's a lot of antibiotics that act as nephrotoxins, so that's always something to keep in mind. And then mechanical obstruction, occasionally, that would be your kidney stones typically. What's going to show, so usually, again, sudden onset, we're going to have elevated BUN, creatinine are going to be up. They maybe have metabolic acidosis and high potassium for acute renal failure. But again, these are similar signs to some of the chronic renal failure. So chronic is gradual, long-term period of time. Usually with acute kidney injury, all those symptoms come on rapidly. With the chronic, some of that stuff is not going to show. They're going to be asymptomatic usually in early stages. Polycystic kidney disease, systemic disorders that lead to kidney low nephrotoxins. So medications over time can cause this. They're going to have basically the key for diagnosing or understanding renal failure and the stages goes down to GFR. So GFR can tell us a lot about acute kidney injury, but if we're really trying to understand the progression of kidney disease, GFR, usually called an estimated GFR, EGFR. We want like 120 milliliters an hour, basically. If anybody's in kidney failure, they're like 90 or less. Going to have elevated creatinine. Sometimes they won't have clinical signs early. As it gets worse, they're going to lose 20 to 30% of that normal GFR, start retaining waste. And they could have anemia because of lacking red blood cell production, elevated blood pressure. So typically with chronic kidney disease, you're typically going to see the hypertension. You're going to see maybe anemia. You could at first see large amounts of urine and then slowly see oliguria, a low amount on later stages, that sort of thing. So again, this talks about early signs: nausea, anemia, fatigue, elevated blood pressure. If there's, again, later stages of renal failure, you're going to start to see that oliguria, dry skin, going to have some neuropathy. Encephalopathy is basically related to confusion, a metabolic just confusion of just delirium, basically. Could affect their physical. Their heart is trying to pump so hard to get blood flow to the kidneys that aren't working, that their heart starts to fail. Metabolic acidosis, we're going to treat anemia. Electrolyte abnormalities is definitely going to be at high blood pressure. Typically, kidney failure patients are going to deal with low sodium and high potassium is the most common electrolyte abnormality of chronic kidney disease. Elevated BUN, elevated creatinine. Azotemia is presence of urea and nitrous waste in the blood. So really you're kind of defining that if your BUN's up, then you're kind of telling the patient that they have azotemia, basically. So if I had chronic renal failure, why does metabolic acidosis develop? Why a metabolic acidosis? Right. Number one, kidneys are unable to excrete hydrogen effectively and reabsorb bicarb. That's one of their main acid-base balance jobs, and they can't do that effectively if they're in chronic failure. Nurse caring for a patient diagnosed with acute pyelonephritis. What clinical manifestation should the nurse expect? So remember that cystitis is a urinary tract infection of the bladder. Pyelonephritis is a urinary tract infection that has infected one or both kidneys. So what do you think the difference in symptoms would be? If you answer number one, you're correct. So dysuria, cloudy urine would definitely be more urinary tract infection with cystitis. Edema, proteinuria, that's more talking about nephrotic syndrome. And hematuria, hypotension, it's not really talking about anything. They'd have hematuria and hypertension with glomerular nephritis. So the only one that makes any sense is pyelonephritis is going to be flank pain. A patient's chronic kidney disease experience hyperkalemia. What life-threatening complication is the nurse most concerned about? Again, trying to put some NCLEX style questions at the end here to really put all this together, right? If you answer number two, you're correct. And lastly, a patient has a history of kidney stones, presents with severe flank pain, nausea, and restlessness. What's the nurse priority intervention? This is, again, trying to think next level nursing here. What would we do for this person? We can already tell they have kidney stones, severe flank pain, nausea, restlessness, and they have a history of kidney stones. So we're calling urolithiasis. They've got kidney stones. What could we do for this? Right. We could encourage fluid intake, but we're probably going to need to actually give them some fluid or fluid resuscitation. So if we're going to do anything, pain relief is going to help them the most right now. And we don't want to make sure they obstruct. And that's why people with urolithiasis with kidney stones, they will just get a a screening, and they'll pee into basically a strainer, and we strain and look for the kidney stones and make sure they're passing. If they're not passing, they're still having pain, then we worry about an obstruction and we need to progress up the chain of command, basically. So I hope that was helpful. That's chapter 18, urinary disorders. We'll continue unit 2 going forward. Thanks for your time and listening. Y'all have a great day. Okay.